So with the new guidelines, this is the time point to start planning for the next access. And that's what the emphasis is from the new guidelines. So as we all see in practice, we have patients with all kinds of problems. Not all patients are equal. And here's this different patient populations that we see. Elderly patients who is on palliative therapy, is receiving dialysis, is different from a young person who has no comorbidities and has congenital disease leading to end-stage kidney disease, and he has an excellent prognosis. Likewise, a young adult with GN who has failed PD, now transitioning to hemodialysis, has a different need. Elderly patients, like we discussed yesterday, can be completely different. Elderly patients who is functionally very independent, works as a volunteer, certainly would benefit from an AV fistula. A morbidly obese patient with diabetes, deep vessels will require multiple interventions if you can get an AV fistula going. And a patient with multiple comorbidities may never get an AV fistula, may have to get an AV graft. So again, individualizing your treatment plan is important because our patients are not equal. So the fistula first and the earlier guidelines promoted fistula for everyone, at least everyone to be evaluated for fistula, so everyone should get a fistula and avoid catheters completely. Now, is that really true? What we have learned over the last 20 years, the fistula first initiative was introduced in 2003, so it's almost 70 years since then. The last guidelines were in 2006, so that's 13 years. So we have now gained enough evidence to at least move forward and evolve into our thinking process. And so the concept of ESKD life plan, like the patient that we saw in the live demonstration, we really need to start planning now rather than wait for that access to fail and then create a fistula, or create a plan which might take some time for that new fistula to mature, and in the interim period the patient will end up with a catheter. So as we know that the CKD advances in various stages, it's a continuum from stage 1 to stage 5 in dialysis. The access plan also should change because our patients who are ultimately, they reach end-stage renal disease, do change from hemodialysis to peritoneal dialysis, back to hemodialysis. They get a transplant, the transplant fails, they are back on hemodialysis. So they are also evolving. So it has to be a lifelong plan. No access is permanent, no graft is permanent, things fail. And rather than waiting for the last minute, we should start making the plan up front and start documenting it, what options are available, what patient wants, and how we can move towards reducing the catheter time, reducing the catheter duration and catheter exposure. So patients do move from PD to hemo to transplant and in the backward direction too. So no two patients are identical, two patients are different, and the plans should be different. So updating on the prior message, yes, fistula first was essential 15 years ago. At least the fistula first initiative was not made for the entire world. It was made with the US population in focus. The fistula rate was less than 20% in the mid-90s. And that's when the concept of fistula first evolved. And that has done its job. Now, almost 65% or 63% of the patients in the US have AV fistula. So fistula first is not ideal moving forward. Catheter last, again, that's not ideal moving forward because there are some patients, as we have seen patients who have a shorter lifespan, they still want to be on dialysis. Those are the patients where creating an AV fistula may not necessarily be the right choice. And in those patients, catheter may be the first choice that one should consider. So the new philosophy is right access for the right patient, for the right time, and for the right reason. So this has to be an evolving process. You cannot just make a blanket decision that every patient needs to get a fistula, every patient should never get a catheter, no patient should ever get a catheter. That's not what is the new philosophy of the new guidelines. So how do we plan it? So this clearly needs a well-designed plan, and it has to be a team effort. And again, all of the members who are involved in managing patients with dialysis, with advanced CKD and dialysis patients should be part of this. Patients should be absolutely in the center. That's key. Life plan, like in our patient, we really need to make a life plan. Even with the first access, when the first access is made, start thinking about what would be the next option if the first access fails. Is the patient going in for transplant? Is the patient likely to have a living donor and the transplant workup and the process is going to be faster compared to a cadaver donor transplant? Access, what kind of access? Is the patient going to be on PD? Is that what fits into the patient's lifestyle? Then the PD catheter needs to be planned accordingly. If the patient is going in for hemodialysis, that needs to be going in accordingly. And finally, the needs of the patient. What exactly are the objectives and goals of care for the patient? And what do we need to do to get to the level where we can provide the right kind of treatment that the patient has opted for? So plan is patients, life plan, access, and needs. The first and foremost thing is patient first. Keep the patient in the center. Rather than making it a population-based decision, it has to be a patient-based decision. Depending on what the patient chooses, hemodialysis, peritoneal dialysis, access needs. What is the patient's access creation plan? Does he have a good vessels to create an AV fistula? Does he have good arteries but not veins? Does the patient want to be on PD? So those are the kind of decisions that need to be taken up front and documented. And like in our patient that we saw, contingency plan, always have a contingency plan as to when the first access fails, what's going to be the next access. What are the remedial measures when the access becomes problematic? Is the dysfunctional AV fistula going to be managed with endovascular therapy, or is endovascular therapy too expensive, or the resources are not available depending on the insurance, depending on the skills level, depending on what the patient prefers, and is surgical option a better treatment than an endovascular option? And finally, if the access fails, what's the succession plan? So sorry about this. I didn't realize that the animation was going like. So once we have all of this documented in the medical records, that completes the plan or the ESKD plan for the patients. And that's when you start treating the patients once the team is all on board. So the new guidelines, yes, it took us a long time to create the guidelines. It's been in works for almost 2 years. So in 15 minutes, I'm not going to cover the guidelines. I'm just going to give the major mission statement of the guidelines. These guidelines were evidence-based. They are patient-focused. They're technologically friendly. So it's going to be an app that will be available, so you can pull up a guideline regarding any particular question you have, and then the guidelines, you can read through it and see if it is applicable for your needs. And more importantly, the guidelines were created with a multidisciplinary team. And the multidisciplinary team included nephrologists, interventional radiologists, included surgeons, included general nephrologists, and also included the input from nursing and epidemiology and statistics. So this was much bigger teamwork compared to the first set of guidelines that were released in 2006. I'll just give you some examples of, a couple of examples of what these guidelines, how do they look. Hopefully the guidelines will be formally published in early part of 2020. They're right now with the publishers and they're going through the editorial process. But if you read through this vascular access needs in prevalent patients, it again highlights the point that we have to keep patients in the center. So guideline 2.12 reads, there is inadequate evidence to make a recommendation on the type of vascular access preferred in prevalent hemodialysis patients based on vascular access outcomes, patient hospitalizations, or mortality. Which essentially means that in an elderly patient, as an example, elderly patients, we really don't know, like I discussed yesterday, that is AV fistula really better than an AV graft? And it all depends on what the patient has along with renal failure. So if the patient has a short half-life, short lifespan, then AV fistula certainly is not the ideal access for this patient. And if the patient is going in for some palliative dialysis therapy, then neither AV fistula nor AV graft is the right access. They need to get, that patient needs to get a catheter. And again, those are clearly defined. So consider it reasonable that prevalent patients use an AV access in preference to central venous catheters if possible, due to the association with lower vascular access related events. So we do acknowledge that AV fistula is the most ideal access, but not necessarily for every patient. And then there are specific circumstances that are clearly defined. So clinical circumstances refer to patient's vessel characteristics, comorbidities, health circumstances, potential exposure time to catheter use, and patient preference. So if the patient really has bad vessels, is there any need to really go in and explore and create a surgery, an AV fistula that's not going to mature? If the patient prefers to be on catheter, even if the patient is fully informed, fully educated, accepts the risks of infection, accepts the risk of central stenosis, still wants to be on catheter, should we be forcing these patients to go in and get an AV fistula or an AV graft? And it's reasonable to have a catheter for short-term or long-term durations, and these terminologies are well described. So what do you mean by short-term and long-term duration? So acceptable short-term duration is AV fistula or graft is created but not ready to be used, so it's maturing. So AV graft, if the patient crash lands into the ER, gets an AV graft, it still takes 3 weeks before you can, 2 to 3 weeks before you can start using the graft. AV fistula may take up to 2 months. So that short term defines these situations. Transplant patient with rejection, PD patients who may have peritonitis and maybe transitioning short term for over to hemodialysis, or they have a pleural leak and that is being fixed, or a hernia that is being fixed. If the patient is going to get a living donor transplant within less than 3 months, then again, AV fistula or AV graft does not make sense. Cases like we discussed on infiltrations, patients may have major infiltration that will prevent the access from being used. You have a short-term indication for central venous catheter use. Long-term use, multiple failed accesses like a last access option, patient preference, patient's quality of life, limited life expectancy, and patient's anatomy in terms of combination of inflow artery and outflow vein that prevents creating an AV fistula or an AV graft. So these are additional points that we have tried to clarify in the guidelines, which hopefully should help improve the discussions with the patient when it comes to informing the patient and educating the patient. So as I mentioned, this whole guideline process involved multiple work group members. I'm honored to be part of this work group guideline of work group, and we've been working together for the last 3 years. And we also included allied health members, allied health professionals, epidemiologists, and statisticians to help us read through the evidence that's in literature. We had an entire evidence review team. The group was led by Charmaine Block. She's from Canada, with 2 vice chairs. Suren Shenoy, he's a vascular surgeon, he's a transplant surgeon, but has tremendous experience with vascular access. Alex Yerslin is an interventional nephrologist, a close colleague of mine. The editorial team members, Tom Huber and Timmy Lee, one is a nephrologist, Tom Huber is a surgeon, and then an entire evidence review team that reviewed over almost 4,450 literature between 2006 and 2015. There are a total of 26 guidelines, and multiple volunteer hours have gone in creating this document. That's all I have is a short overview of the guidelines. It's been a wonderful time for me to get to it. We had a great time in the evenings. By the time we came back, it was 2 o'clock. But it was a great experience to see the cultural, vast cultural variety in Peru. So thank you very much for your kind hospitality, and thank you very much for inviting me here. Thank you.